Welcome viewers, welcome you all to our today's clinical discussion. Let's today talk about all about the our clinical knowledge and to share with you the few things about hypertension. So, we all know in the day-to-day practice, one of the most common diseases that we encounter that is hypertension, and sometimes we get puzzled when to be start a treatment with hypertension, how to approach a patient with hypertension, and whenever the emergency of hypertension happened, what will be our approaches. With no more wasting of time, let's move to our today's session along with our slide, please. Let's come to our first slide. We are talking about hypertension. The hypertension or high blood pressure is very common, and it's a serious condition that can lead to or complicate many of the health problems. So it's not only a single entity, it can involve many of our part of our the physiological systems. And whenever we made the diagnosis of hypertension, it is made when the systolic and diastolic values rise above the specific threshold that corresponds to the level of blood pressure at which the risks of cardiovascular complications and the benefits of treatment outweigh the treatment cost and also the potential side effects of the therapy. So if we move on to our next things that when we can do the diagnosis of hypertension, firstly the prevalence rate. Although it's a just older bit data, but the most concrete data are not coming in every year. So we are using these. The globally 1.13 billion people are hypertensive. Just look at the number. It's a very huge number. The overall prevalence of hypertension in the adult is around 30 to 45%. And the globally male and female is 24% and 20% respectively. So that although there is a difference between the male and female ratios, but almost they're the same. Although the male predominance is slightly present according to the data. So 60% of the hypertensive people's aged greater than 60 years. In Bangladesh, about 11 to 18% adult and 40 to 65% of the elderly people presently having hypertension. The non-communicable disease survey in Bangladesh in 2010 showed about 18% population over the 25 years of age have hypertension. And another scale study in Bangladesh in 2011 shows that is 26.4% of the population over 35 years of age having suffering from hypertension. Although these data may vary according to the time, according to the area, according to the demographic variety, and according to the variety of the service status. So let's move on. How we going to diagnose this hypertension? The diagnosis of hypertension should not be based on a single set of BP recording because it is very much important because in any circumstances the BP may shoot. So single office visit in the blood pressure is not enough to diagnose the hypertension unless it is increased up to the grade 3 hypertension and if there is a clear indication or if there is clear cut evidence of the target organ damage, then we can even diagnose it as a single setting of hypertension. If it comes to the etiology, if we can tell us that we don't know about the etiology of hypertension, in the 95 out of 100 times you're correct. Because in the 95% cases, it's a case of primary or essential hypertension. In the 95% of the cases, there is no specific underlying cause is found. So we can, based on the genetic factor, we can, based on the other contributing factors that is related to the genetic mechanisms. Whatever the rest of the 5% cases, what we termed as secondary hypertension, there is a primary cause associated with the hypertensions. That may caused by the renal disease, that may caused by the thyroid disease like hypothyroidism or thyrotoxicosis, that may caused by the phacocytoma, that may caused by the Cushing syndrome or hyperparathyroidism, or any other abnormality like other connective tissue disease and other things. But the percentage is very few. Now move on to, although we are now moving on to the next GNC, we are going to just follow the last before the GNC, that is GNC 7, because that was one of the most concrete classification. If we categorize them, then the normal blood pressure, the pre-hypertension, the hypertension stage 1, hypertension stage 2. You can see the values, the systolic blood pressure below 120 and diastolic below 80, that is up to the normal. When the systolic blood pressure from 120 to 139 and diastolic blood pressure is varies from 80 to 89, we can call our term the patient is pre-hypertension. When the systolic BP is between 140 to 159 and the diastolic one is 90 to 99. We can call this hypertensive stage 1. And there is hypertensive stage 2 when the systolic blood pressure is more than 160 and the diastolic blood pressure is more than 100 millimeter of mercury. So, besides those diagnostic criteria, we can also tell there are some other situations when only systolic blood pressure can be raised, only diastolic blood pressure can be raised. So when we can diagnose the hypertension with a single setting, with hypertension with the evidence of life-threatening end organ damage, when the blood pressure level is greater than 220 over 125 without the target organ damage, and 50% of the affected patients develop overt hypertension in 4 years. So the pre-hypertensive patient should be monitored annually to see either they are developing the main course of hypertension like stage 1 or stage 2 or malignant hypertension. If we move to the next classifications by giving by the British Hypertension Society, we can see there is optimal, there is normal, and there is high normal blood pressure. But the normal range ends up to the systolic up to 139 and the diastolic up to the 89. And we can stage grade 1, grade 2, and grade 3. Here's the grade 3 where the systolic blood pressure rises equivalent more than 180 and the diastolic blood pressure is more than 110. British Hypertension Society also given emphasis on the isolated systolic hypertension that is more commonly prevalent in the elderly. That is isolated systolic hypertension grade 1 that is 140 to 159 of the systolic with near normal diastolic blood pressure, and in the grade 2 that is greater than or equal to 160 millimeter of mercury systolic blood pressure and near normal diastolic blood pressure. There are another classification that we will move on to, the classification of hypertension, that is American Heart Association 2017 guidelines. They marked the hypertension categories as normal, elevated, high blood pressure, hypertensive that is hypertensive stage 1, the high blood pressure that is hypertensive stage 2, and the terms a new term that is hypertensive crisis. Whenever, according to the British classification, it moves to the next step, there is the last step, we can then tell it that more than 180 millimeter of mercury of systolic pressure and higher than 120 millimeter of mercury diastolic pressure, we can mark this as hypertensive crisis. All of these terms or all of these misnomers are commonly actually used to be diagnosis the case of hypertension. So we can make those cases or classifications, all of them may count to be treated as hypertension. So if we can think about the 2017 and 18 and 19 guideline for the preventive detection and evaluation and management of high blood pressure in the adults, the classification of GNC 7 and later on the GNC 8, we can see the pre-hypertension level rise in the same thing. The pre-hypertension level is up to the systolic blood pressure 139 and diastolic blood pressure is up to the 89. In the stage 1 hypertension, the systolic barrier is up to 159 and the diastolic barrier is up to 99. And after that, that can be in the stage 2 hypertension. So after the classification and after the demographic variety, now let's move on to our initiation of the treatment regarding the hypertension. What we can do, what we can think regarding the management of the hypertension. We know that any metabolic disease or any metabolic condition, one of our one of our main focus will be not only to give the pharmacological management, but also to give the lifestyle modifications. Whatever we have already learned from the many topics, that lifestyle modifications have an very intense effect in terms of controlling of hypertension in all age group in divide of all side effect and other criteria. So if we initiate the blood pressure lowering treatment, first of all, we have to think that what we can do with the lifestyle modification. We know there are simple lifestyle modifications like a disciplined lifestyle. We will arise in the early morning, go to the bed in the early, we will take our meals properly. We have to avoid the bad fats in the meals, and we have to avoid the extra meals in between our meals, and we have to do a light aerobic exercise for 30 minutes or can only do and moderate walking for 30 minutes every day to maintain a balanced lifestyle. Those patients who are already been addicted with the smoking or alcohol should cease the alcohol and smoking as long as they are in the category of the pre-hypertension group. Those people who have already developed hypertension stage 1 and stage 2 should go more and more intense lifestyle modifications. And we should address not only the hypertension, we should address along with the complications of the hypertension and along with other comorbidities that is prevalent with the hypertension, like diabetes mellitus, like chronic kidney disease, like ischemic heart disease, like the stroke, the cerebrovascular diseases, and other neurological diseases parallelly to be treat the hypertension. So let's come to our slide. When the blood pressure level is just high normal blood pressure, the pre-hypertension level, the lifestyle advice is enough to be controlled. We can consider drug treatment with very high risk patients with such as those have cardiovascular disease or those have some coronary artery disease, that is ischemic heart disease. In the grade 1 hypertension, we have to do lifestyle modification. Along with that, an immediate drug treatment in high or very high risk patients who are suffering from cardiovascular disease or any kind of renal disease or any kind of ischemic heart disease. Then we can give in generalized drug treatment in the low to moderate risk patients without cerebrovascular disease or ischemic heart disease or renal disease, but we can wait 3 to 6 months by giving lifestyle modifications even to these stage 1 hypertension patients. Now move on to the grade 2 hypertension patients. It is very much important. Grade 2 hypertension patient, we will give the lifestyle modification to all the patients. That is to be maintained, not to be forgotten this, that we have to give lifestyle modification also from the grade 2 or stage 2 hypertension patients. But along with that, the immediate drug treatment is also necessary for these patients. And we can aim to control our blood pressure within 3 months of initiation of the treatment. In terms of grade 3 hypertension, when blood pressure is greater than or equal to the systolic pressure greater than or equal to 180 and the diastolic greater than or equal to 110, along with the lifestyle modification, the immediate drug treatment to all patients, and we have to aim to control the blood pressure within 3 months. But in the grade 3 hypertension, along with these, we have to also remember about the target organ damage that is done in the grade 3 hypertension very commonly. We have to do the all physical examination of the patient, starting from the eye to the toes, to see is there any already established complications has developed, and as long as we have to search other comorbidities, and also always look for any hypertensive crisis. What we tell this, because during the stage of diagnosis of hypertension, we have to address all these things about the other comorbidities, other target organ damage, and to be chance of development of complications. So let's move on to the history in our next slide. Why we give so much importance to these points during the first diagnosis of hypertension. So let's move our next point. Why should we have a very clear knowledge? We all knows about the US President Franklin D. Roosevelt. I think many of you can remember about his history. If we just follow the history of this, okay, thank you. So whenever the starting of the treatment of the hypertension, we should not only giving importance to the present condition of the hypertension of the patient, but also we have to give importance whatever that is happening besides the hypertension. What are the target organ damage? What are the main other stream of comorbid conditions that we have to combat? Because if we not combat with the other conditions, then we can mislead some points and we can lose our patients. All of you can just hear one of the renowned person of this world, the US President, the Franklin D. Roosevelt, in the history. Just look at the clinical scenario of this most honorable gentleman in the course of time. In the 1937, he was diagnosed as a case of hypertension. He was in a very much stressful lifestyle at the time. In the 1938, he developed proteinuria. In the 1941, there was development of the anemia that was an indicator of starting of early CKD with then blood pressure of 188 mean values and with 1/105. In the 1944, the proteinuria was turned into the massive proteinuria. In the 1944, the simultaneous the cardiac complications in the LVF developed. In Dane, the pulses tolerance with blood pressure of 260 over 150 persist. In the January 1945, the ischemic heart disease and the myocardial infection started. In the 8 weeks later, the severe headache with an intercerebral hemorrhage and die within 2 hours. The blood pressure was 300 over 190 during that diagnosis. So, if we just follow the clinical course of this gentleman, we can easily understand how notorious can be the stage 2 or stage 3 hypertension be at the time of diagnosis. So we have to address the very high systemic arterial blood pressure in a different way. There is no well established definition for the very high systemic blood pressure level. We all know that the very high systolic blood pressure level, we have to just think when the blood pressure level is above 180 over 120 millimeter of mercury, the grade 2 hypertension or stage 3 hypertension according to the British Hypertension Society, or the hypertension crisis along with the American Heart Association classification. So the blood pressure when it is above the level of 180 over 120 millimeter of mercury, we can be considered a very high systemic blood pressure. The commonest types of very high BPs that is undiagnosed for a long time, asymptomatic patients that can be untreated for the long time and that can be undertreated or can be maltreated, or the less adherence to the patients to the treatment protocols. So, what the very high blood pressure can cause? It can causes the rapid development of the renovascular disease, the eclampsia of the preeclampsias, the acute glomerulonephritis, the phacocytoma, and with the other causes, the antihypertensive withdrawal syndromes, the head injury, and the CNS traumas, and the renin-secreting tumors. And apart that, any mal-diagnosed or any misdiagnosed cases of hypertension or any poor adherence of the hypertensive patient can lead to this hypertensive crisis. So hypertensive crises are acute, the severe elevation of the blood pressure that may or may not be associated with the target organ dysfunction is very much important. It is two subsets, that is hypertensive emergencies and hypertensive urgencies. When there is associated target organ damage, we can tell this as hypertensive emergencies. When there are no associated target organ damage, we can term this as hypertensive urgencies. But most of the cases, the treatment protocols remains in the same arena. So the hypertensive emergencies is a subset of hypertensive crisis actually that are characterized by acute and severe elevation of the blood pressure, often greater than 180 over 110 millimeter of mercury, and when it is associated with the presence of the impedance of the target organ dysfunction. In the hypertensive urgencies, that is characterized by similar acute elevation of the blood pressure of that hypertensive emergency, but not associated with target organ dysfunctions. Although hypertensive emergencies can lead to significant morbidity and potential fatal target organ damage, only 1 to 3% patients with hypertension will have developed hypertensive emergencies during their lifetime. So, although the percentage is very low, but whenever it happens to anyone, that is 100% for him. So even a disease condition that is prevalent for 1% of the patient, we should give importance because the person who is effective for him, the percentage is 100%. Within the hypertensive crisis, hypertensive emergencies accounts only around 1/4 of the presentations compared with the hypertensive urgencies, which account for around the rest of the 3/4 of the presentations. So the common hypertensive emergencies are, we all knows, the malignant hypertension or accelerated hypertension, the hypertensive encephalopathy, the intracranial hemorrhage, what happens to our honorable US president, and we can also bring as acute ischemic stroke. We can also see acute myocardial infarction, acute left ventricular failure, the aortic dissection, often commonly misdiagnosed in many of the cases, started as the pain in between the scapulas, and the preeclampsia and eclampsia during the pregnancy. So this can affect all the target organ. We can just see that the examples of the acute target organ damage, that is, we can see the cerebral infraction can be prevalent in 24.5% of the cases, the hypertension encephalopathy in 16.3% of the cases, intracranial hemorrhage in the 4.5% of the cases, but it's always life-threatening, the intracranial hemorrhages. So we should always give importance to this. And we can see the other like acute congestive failure or myocardial infection. Those are not lesser in the percentage. In the ocular manifestations, those also have some importance, and the elevation of the liver enzyme that can be lead to the HELP syndrome, that is also important. Let's come on the malignant hypertension for a such small discussion. The malignant hypertension is actually a syndrome that is associated with an abrupt increase of the blood pressure in a patient with underlying hypertension or related to the sudden onset of hypertension in a previously normotensive individuals. So the absolute level of blood pressure is not as important as its rate of rise. We have to always think about this. In malignant hypertension that is characterized by the severe hypertension, usually grade 3 hypertension, associated with the fundoscopic changes. We can see any flame-shaped hemorrhage. We can see any papillodemas whenever the fundal examinations. We can also see microangiopathy and disseminated intravascular coagulation. We just can ignore the silver warring or stage 1 type changes in malignant hypertension. The hallmark of this condition is small artery fibrinoid necrosis in the kidneys, in the retinas, and in the brain, which is very much notorious. The term malignant reflects the very poor prognosis for this condition if it's remain untreated. And even if treated, the target organ damage can be reversed in very few cases. So accelerated hypertension is a subset of malignant hypertension in which all of the features of malignant hypertension is present except the fundoscopy when there is no papilledema present. So we can easily term accelerated hypertension also as malignant hypertension if the papilledema is not present and the fundus examination is normal. And the another crisis moment when that can be happen, that is hypertensive encephalopathy. It is one of the most common hypertensive emergencies. Is occurred due to the failure of the autoregulation of the cerebral blood flow. And the sign and symptom of hypertensive encephalopathy may include the severe headache, nausea, vomiting, the focal neurological signs, and the alteration in the mental status. If untreated, then it may progress to stupor, the coma, the seizures, and even death within the hours. It is important to distinguish between hypertensive encephalopathy from other neurological symptoms that may be associated with hypertension, such as cerebral ischemia or intracranial hemorrhage or thrombotic stroke or seizure disorders. Let's move on to our next entity, the pregnant patients. So hypertension in the pregnant patients, the severe acute hypertension when the systolic blood pressure in the same arena greater than 160, the preeclampsia, the eclampsia patient when the blood pressure level is elevated, the HELP syndrome, which is always life-threatening, and the hypertensive emergencies when the blood pressure is around 240 systolic and 140 of that of diastolic. So we should always give addresses to these patients. Let's then move what we can do along the diagnostic approach by laboratory investigation in case of hypertension. So the we can do the fundoscopy. The fundoscopy can give a very good clue about the about our next scenario, that how can we give the diagnosis of the hypertension. We can also do a 12 lead ECG. You all know that is ECG is very much important in terms of diagnosis of many cardiac disease. Not only that, it also gives and clue about the level or about the duration of the hypertension. We can see the left ventricular hypertrophy. We can get it the diagnosis of hypertension for a long duration. We can see the complete blood count, and we can see the fibrinogen levels, the creatinine, the eGFR, which are commonly seen, the electrolytes, the haptoglobin, although not commonly seen, but we can see the urinary albumin creatinine ratio to see the renal changes, the urine microscopy for the red cell, for the reticulocyte counts, and also the pregnancy test of the woman in the childbearing age, which is also very important. If we go to the some specific test, what we can do the specific test in case of there, that is we can do the troponin I, we can do the creatine kinase MB, we can do the chest x-ray to see the fluid overload, we can do the echocardiography to see the aortic dissection, heart failure. Always remember aortic dissection is commonly missed in terms of malignant hypertension, so never forget these. The CT angiography of the thorax, the CT MRI of the brain, the renal ultrasound, the urine drug test suspected, the what we have do for the diagnosis of the phacocytoma. We should always go to the address of these things. So after the diagnosis, we have just running out of time. We should be go in first in case of management, because if we can diagnose the disease, if we can classify the disease, the management is far more easier. It can be even done by the reading your book besidely. It can be done by searching the net over the YouTubes and over the Safari, over the Medscapes. You can see the treatment options everywhere. The mainstay of treatment is to diagnose the case. Either it is a case of stage 1 hypertension or pre-hypertension, or it's a part of hypertensive emergency like it an accelerated hypertension or malignant hypertension, or with an established organ damage or any complications that can be due immediate life-threatening conditions. So what we can do for the management, that is we have to just address which degree of damage and rapidity the hypertension develop. We can do think the blood pressure level is not to be as important as the rate of blood pressure rise. The patients with regularly, those who have hypertension, can often tolerate the higher blood pressure level without sometimes any symptoms. Most of the patients who present with severe hypertension are regularly chronically hypertensive, and in the absence of any acute or chronic organ damage, the precipitation of the lowering of the blood pressure may result in significant morbidity and mortality. So we should not go to the aggressive management in these terms of patients. That should be always remembered. Look at this flow chart. If the systolic and diastolic blood pressure is above the malignant level, then the target organ damage or the new process or worse. If those target organ damage are present, then we can term this as hypertensive emergency. Then the patient can be admitted in the intensive care unit. The patient should be treated in the intensive care unit. Then the conditions, other conditions like aortic dissection, the severe preeclampsia, or the cytopenia crisis or thyrotoxic crisis, we have to set the target to be the systolic blood pressure of 140 millimeter of mercury during the first hour, and to the 120 millimeter of mercury in case of aortic dissection. But if those three conditions are not present, even though patient has some intracranial hemorrhage, our target blood pressure is then to systolic to 160 millimeter of mercury, and diastolic is 100 to 110 millimeter of mercury. So until otherwise, the aortic dissection, there is severe preeclampsia or phacocytemic or thyrotoxic crisis, our target blood pressure for malignant hypertension will be systolic 160 and diastolic 100. If there are no target organ damage in the hypertensive emergencies, we can just maintain the reinstate or intensify the oral antihypertensive drugs, and can be wait to be controlled over the time of a target of 3 months. The hypertensive emergencies that demand the immediate reduction of the blood pressures. The key consideration of the treatment strategies are establishing the target organ that are affected, whether they may require any specific intervention other than blood pressure lowering. Suppose if a patient have intracranial hemorrhage, he may need the life support for his ventilation support, he may need institutional support, he or she may need some other support. If there is renal shutdown, he or she may need some support from the hemodialysis. So all these should be approached, and all those should be addressed simultaneously to be control of this disease. What are the treatment goals? In the first hour, the reduce the mean arterial pressure by 25%, where our diastolic blood pressure goal is greater than or equal to 106 millimeter of mercury. The next 2 to 6 hours, the systolic blood pressure goal is 160 millimeter of mercury, and diastolic is 100 to 110 millimeter of mercury. In the hours 6 to 24, within first 24 hours first day, maintain a goal for hours 2 and 6 hours goals, just to be sustainedly maintained that previous goal. And the 24 to 48 hours, in the outpatient BP goals, that we always maintain the systolic 140 and the diastolic below 90. In the exceptions, that is reduce the systolic blood pressure to 140, below 140 in the during the first hour of the presentation in case of eclampsia, phacocytoma crisis. And in case of reduction of systolic blood pressure greater than 120 millimeter mercury in case of aortic dissection. Just to remember these 2 or 3 conditions. In other conditions, the treatment management is all the same. So, in the ischemic stroke, what we think the current guidelines is use of thrombolytic therapy, and the other target organ damage should be addressed, and the severe elevation of blood pressure, if it is greater than 220 millimeter mercury, and diastolic is 120 millimeter of mercury in terms of that patient. And in case of thrombolytic therapy is warranted, then the high blood pressure goal for initiation thrombolysis is less than 185 over 110 millimeter of mercury, and after commencement and throughout thrombolysis and for the subsequent next 24 hours, that goal changes slightly to a goal blood pressure less than 180 over 105 millimeter of mercury. In the other ischemic stroke circumstances, other than target organ damage or severe elevations, requiring treatment of elevation blood pressure, the goal is more modest. It is reduction of 15% of the mean arterial pressure over 24 hours. In patients with hemorrhagic stroke, that is always life-threatening condition, we should always address and suggest the guideline for initiating the antihypertensive therapy to maintain the whenever the systolic blood pressure of 180 and diastolic are more than 130. But our target will be in the first 24 hours to 48 hours will be systolic blood pressure 160 and diastolic blood pressure 100 millimeter mercury. So we have to categorize what I have told in the earlier in terms of managing malignant hypertension. We have to first identify either it is hypertensive urgency or emergency or accelerated hypertension or malignant hypertension. In terms of everywhere, you just go through specific goal along with set by the guidelines of all the world. We're coming almost the end of our presentations. We'll just tell about the few drugs which are commonly used intravenously: the levetol, the sodium nitroprusside, the nitroglycerin, which is now most commonly used in the intensive care unit, and the hydralazine. I can tell that sodium nitroprusside and hydralazine is using very race. The levetol and the nitroglycerin is now using in most of the setup in our countries and in all over the world. So, dear viewers, if we think about hypertension, never think hypertension as a disease. Always think that it can do many diseases. It can damage all the organs. It can do a lot of harm to the body that can even lead to the death in acute setting. And besides that, after a long, long time, patients suffering from uncontrolled hypertension, there are morbidity develop. Just think about the patients who have cerebrovascular disease with hemiparesis, lost his or her functional capacity for the lifetime. If he develops or she develops the chronic kidney disease, think about the lifetime cost of the hemodialysis at the end of the points. If he or she develops ischemic heart disease, let's think about the overlying cost and the reduction of his working capability that will hamper his lifestyle more and more. So never think hypertension as a simple disease. Don't try to treat hypertension very casually. Always gives emphasis to the lifestyle modification and always try to classify in which level the hypertension is presently in the persist in the patient and just to address in that way. There's a very simple way of management of hypertension if we are a little bit careful in terms of management. Thank you for your patience sharing. Looking forward to talk with you again and again. Thank you all.